Hello, welcome to First Friday Fertility. I'm Dr. Preston Parry, and today we've got a little bit of a different setup and layout because what I'm doing with this is something that normally is reserved for med students and even for residents. So if you are wanting a deep dive to understand a lot of the core principles of fertility, this is what the doctors are taught. But as always with anything, again, coordinate with a specialist, see if this does apply to you or there's new discoveries that might change what we know. But these are general medical principles that for a lot of times help shed light on where people stand. But I call it rethinking fertility because I do think we have to rethink where we are for a lot of things. Because if you look at fertility just as a general concept, by the way, I talk about letrozole and metformin off-label. I have intellectual property rights, patents for things and devices, that I've helped develop. So things that I admit, that I see the world a little bit differently, but these things we want to be aware of. I always tell med students, how do you think about patients? Why aren't they getting pregnant? How do we test them to make sure that what we think we know is actually true? And then how do we improve their odds? Most of what we think about fertility really comes down to these three things for what people really need to understand for a fundamental understanding of fertility. But here's the thing. Many of you who are watching this may actually be more informed than many physicians and OBGYNs in the country by the time you get through this. So one of the first concepts I start with is saying, what is wrong with this picture? I ask what's wrong, and one of the things I point out is that the uterus is irregular. Normally, the amniotic sac, normally it's symmetrical. It's like an airbag. But in this case, you don't have that symmetry. And the question is why? And the reason is you've got no uterus. This is pregnancy after hysterectomy. Now, normally I would think hysterectomy to be a sterilizing condition, but it means we've probably got to change the term, fertile versus infertile. So infertile, unable to achieve a pregnancy, I think we need to think of people as subfertile. They can get pregnant spontaneously, but it's possible. Most people are in the subfertile. Now, if you're truly missing sperm, eggs, tubes, uterus, you have none of those, tubal ligation, you had a hysterectomy, then you're probably infertile. Most other people are on this continuum that are subfertile. If you had to know two things for patients on infertility to predict where they are, what would they be? Female age, yes. But here's the thing. You could be 25 and you lost the tubes from a previous pelvic infection. Doesn't matter, they're 25. She could be 20. The guy is without sperm. It doesn't matter that she's 20. So what would be the other thing that matters really beyond age? I would say is duration of subfertility. If you've gone a long time, women tend to get pregnant quickly. So if you've gone a long time, that's telling you something. And duration is how everything comes together. Now, eggs, age matter. When women have never tried to get pregnant, a single act of unprotected sex, 50% are pregnant in the first month if they have a single act of sex just prior to ovulation. But as you get a little older, it's about 40%, 25 to 34, 30%, 35 to 39, even 40. If you've never tried to get pregnant and you're 40, you might have better odds than you would think. And the reason is relating to eggs. And I say at 18 to 25, almost all the eggs are normal. 25 to 34, especially as you start getting 34, a little more abnormality, 35 to 39, more abnormality. And certainly as you start getting to 40, you need 4 eggs often to find a chromosomally normal. But that's for people who have normal fertility. The older you get, the more likely egg quality is driving things. And at 25 to 34, you can start seeing it being 2 eggs, even 3 as you get to 34. 35 to 39, you might be in the 3 to 4 eggs, especially as you get closer to the 39. And at 40, you might need 8 to 16 eggs before you find a good one sometimes. You can have people who have a good quantity, but the quality isn't always there. So some women in their early 40s might even need a year before even finding one good egg. So this is sort of a driving thing for many women, and that's why we pay attention to eggs. The next thing is saying, and this is again, ballpark figures, you can argue the numbers and there's some nuance there. But if they're 50, 40, 30, 20 for the first month, by a year, it's more 4, 3, 2, 1. So you double the amount of time trying, odds get cut in half. And that's really important because the 25-year-old who's been trying for a year can have a lower pregnancy rate than the 35-year-old who's never tried. She may be younger, but it's more likely she should have been pregnant already in something that's problematic than for the 35-year-old who never gave it a shot. The numbers I'm giving, by the way, for these estimates derive in part from this and some other studies put together, but to ballpark say, where should people be? And if you look at this number, or this study, about 70, 75% of women are pregnant within 3 months of stopping contraception. And if you get 6 months, it's closer to 85% or so. And if you give it a year, 90, 95% of people will have already conceived within that 12-month period. And that's the top curve. The bottom curve says, if you aren't pregnant and you give it more time, what's the likelihood it would actually happen? And if you're at a year, the odds are about 5 to 1 against that if you keep going, you'll be pregnant in the next several years. And if you're at 18 months, it's almost 10 to 1. So the point is, most people get pregnant quickly. And people say, look, hey, I've gone 2 years, I might get lucky. And you know what? They might. It always can happen, and you can be surprised. But I remember that Dumb and Dumber line. Remember where, again, if you've ever seen the movie, again, they're saying, Lloyd Christmas is saying, so, what are my odds? And Mary says to Lloyd, not good. And he says, you mean not good like 1 out of 100? And she says, oh, it's more like 1 out of 1,000,000. And he's saying back to her, so you're saying there's a chance? And I think, we do have to say, look, people can win the lottery, less probable things can happen, but you want to say what is realistic, what is probable, how do you give people a reasonable sense of what things are going to be and what they can expect? So, when should you seek evaluation for infertility? People always say if it's more than a year, that's a reasonable state. And if you look at that study I just showed, if you've gone a year, hasn't worked out, probably 5 to 1 odds against things working in the next year or two spontaneously without a radical change or treatment. You want to be more assertive, they're over age 35. I joke, if you're Betty White, you may have waited a little long to see a fertility specialist, as this couple in the picture would have. So, as time marches on and people start losing eggs in their reserve faster, you want to accelerate things. And people sometimes say 6 months there. But again, it depends. Talk to a specialist about that. If you need advice, there are couples who can do it wrong. I've had couples bring in basal body temperature charting, and they're pointing to the point where the temperature goes up. Well, the temperature goes up, and that's the moment they just had sex. It means you're 3 days after ovulation. So it's too late. So you definitely want to get advice if it's taking a strain. This is the thing. If subfertility is causing you stress, you want advice. Don't destroy the relationship for the sake of expanding it. I remember a couple, she had bad tubal disease, was coming in, we were talking about the fact that sperm and egg were very unlikely to meet, and if they did, there would be a high risk for ectopic or tubal pregnancy. And the husband said, I don't know if we can afford IVF. And she just turns to him and says, how much do you think the divorce attorney is going to cost? There are strong procreative images, and I would say don't destroy the relationship for the sake of expanding it. Take care of each other, be well, and get support for where you are realistically so you aren't having false hope in something that can never return upon it. And then also if there are known risk factors. If you had a tubal ligation, you don't need to wait a year to say, hey, maybe I should see a fertility doctor. I've got to try the old-fashioned way. If you have PCOS and you don't ovulate, if the husband doesn't have sperm, if you have a female partner, and your wife has very low sperm count. That might be something where you want counseling and support before you go too far on things. So I always say evaluation overrides advice from friends and family. All these people who failed contraception thinks that makes them an expert on fertility. And people get so much horrible advice from friends and family. It's sort of like, oh, my heart is healthy. Let me tell you what your cardiothoracic surgeon really needs to do for surgery. No, this is very specialized, and a lot of people give bad advice. Now, classically, you say unexplained is 20%, endometriosis 10%, tubal factor 15, and ovulation 25, male factor 25, other 5. And some people even say, by the way, 50% male, 50% female. I think that's very different from what I really see. I think it's magnanimous to say, hey, both people have a part, and it's true, they do. But women have a lot more going on than men. The guys provide the sperm. Women have the eggs, they have the tubes, they have the uterus, they have to carry it. Women have a lot more that can go wrong. In fact, I would say a lot of the unexplained really is tubal factor or egg factor that wasn't picked up with a lot of classic testing. I think that, a lot of fertility does have an underlying source. So I'd even argue with these numbers, and especially because they can also overlap. It's not clean. But I would say the number one thing I see is tubal factor. Number 2 relates to ovulation. And then 3 and 4 really are sort of more uterine and sperm factors for what I see for things. And of course, some combinations of the two. Again, this is where I see personally for things as I do my best estimates. The 50%, by the way, where I put for anovulation for things, that's also including diminished ovarian reserve, some other quantity quality issues, but that's also as you get to more people. But I do see a lot of all these things. And by the way, for the 5% male factor, I'm not counting offshore work where the guy's never there, not counting where it's a same-sex partner for things. But again, tubal factor actually is probably my number one of the clean classic origins, but I see a lot of other things that matter. So how do you think about it? I would say it's not easy, but it's simple. Boils down to 4 things. Got to have sperm, got to have eggs, they've got to meet in the tube, and ultimately have a place to attach in the uterus. You cover those 4 things, most of the things that are relevant for fertility, you can pick up. And that's my family, my boys and my wife for things. And we had children in our late 30s and then 40s, for Marcel first, then Lucas. So I've, been a part of this, and, we've had lower egg counts for ourselves. So I know some of the anxiety that can come with some of these things. But it really, sperm, eggs, tubes, and uterus. Now, for how you think about this, testing the core 4, sperm, eggs, tubes, and uterus. For the sperm, this is a very common, description of a semen analysis. I tell people often to forget it. Really focus on one thing, the total motile count. Volume times concentration times motility. Is there, volume there? How many sperm are in that volume? And how well do they move? And if you figure that out, that's the total motile count. And normal is about 60, 80 million that I often see. 15 million is the total motile sperm is the WHO cutoff. But ballpark total motile count is a pretty good proxy for figuring out most of it. Now, I have 15 million is the 95th percentile cutoff. I remember one day I had 2 people come in, one in 14 million, one in 16 million. One was technically abnormal, one was normal. There's no difference between the 2 of them. It takes about 10 million total motile sperm in an active intercourse for one to find an egg. If you're at 15 million, it means 1 to 2 sperm find an egg each month instead of 6 to 8. That slows you down a bit, but that's not the end of the world. But as you start getting lower, as you get to 1 million total motile sperm, that might mean, 1 to 2 sperm a year find the egg. Or, if you get to 100,000, then it's every 8, 10 years, that a sperm find an egg. So that's where sperm starts mattering. And by the way, the reason I also like the total motile count is it corrects for some lifestyle variation. Some guys want to hold off on ejaculation to build up their reserves. And they end up with, these really high counts, but the sperm have outlived their shelf life. They're all dead. And they think, oh, something's wrong. There's nothing wrong. It's just that they had a more boring month than they might have had otherwise. But their sperm are probably fine. Conversely, I get guys who are worried about collecting and they do a practice round the night before or the morning of. And then the sperm, the motility is through the roof, but the count is down. Again, normally you abstain for 2 to 5 days before providing a sample for insemination or a semen analysis. But if you have some variations, still the total motile can somewhat offset that a bit. So that's what we look at. And by the way, for morphology, there are a lot of guys who say, oh, my morphology is bad. You can have normal is 4% or above. If you are at 3%, but your count is 200 million, that's the same as if you eliminate half the bad sperm, you had 100 million with 6% morphology. Most likely there's not an issue. There are a lot of guys out there with funny looking sperm that make very cute looking kids. The most morphology issues are picked up by total motile count. And so one of the rare exceptions I've seen is post-pubertal mumps. Now, I'm a person who believes in vaccination. I think it's saved a lot of people, and there are a lot of people where, they'd have polio and mumps and all kinds of horrible things. My dad's earliest memory is of the whooping cough from having had it. So I think that, there are a lot of things we don't realize how bad it is without vaccination. Similarly, I've seen you can argue the numbers, and there's some nuance there. A 0% morphology and the total motile count is fine, is with post-pubertal mumps. That will have bad effects on sperm that last. So that's just something people often don't realize for things. That's for the sperm. For testing the eggs, age is for quality, and you do antral follicle count or AMH for quantity. So these are 3 women, all in their mid-30s, very different ovaries. And you're looking at the black spots. Now, the first ovary, small ovary, it's about 1/10 the normal dimension. And then you can't really see the black spots in there. So that person actually had done meth in the teens, cleaned up the life, and then in her 20s, and then 30s was ready for having a child. Well, there were no eggs left at that point. And it was in sort of not ovulating and not having periods. Second person had ruptured appendicitis, had been in the hospital for 2 weeks before they could do her appendectomy. So she had bad pelvic inflammation. And the third was anovulation, just this overabundance of eggs. And you see all those black spots throughout the ovary. Interesting thing. I say these are 3 women about the same age, very different ovaries. All of them did get pregnant. The first one I called, later to check on her and say, hey, there were some things we could look at, and she'd been spontaneously pregnant. Now, usually in her case, the uterus would be small, wouldn't release eggs, but, she happened to release a good egg, and there happened to be sperm there for it, and she got lucky. Second person got pregnant, but it was an ectopic or tubal pregnancy, later got pregnant with IVF. And then the third needed oral medication and insemination to ovulate and then get pregnant. So, you never say anything is 100%. The rare can happen. But, you can look at the eggs and have an ultrasound and have a very good sense of where things are without doing blood work like AMH. I like the ultrasound because it's an instant answer. And the other thing is, it gives me a sense of nuance. I think a lot of people, when they look at antral follicle count or AMH, they treat people as an absolute. And it's on a continuum. Hey, you know what? For your age, at 35, you should have about, 16 eggs, 8 per ovary that you can see ballpark. If you see 12, it might be a little bit older than the biologic age, but it's not diminished. Hey, you're at 7. Some people use an antral follicle count of 6. It's low, but it's still where you can work. It may not change your management other than say you might be max dose for IVF and you might have less time to get pregnant. If you are 35 and you have an antral follicle count of 7, after you deliver, you may want to go straight into things relative to holding off till 38 or 40, where that antral follicle count may be even lower. Okay, the most controversial thing I'll say all day, but isn't, do you need to test progesterone levels? According to national guidelines, really doesn't help from my understanding of them because progesterone's pulsatile. This study from Philip Corey showed, hey, it was about 5 at 5 in the morning, and then by 6 in the morning or 7 in the morning, it was 35. You can see different levels. And more than that, how does it change management? If you're doing it to see if a person ovulated, you just wait a week. Are they pregnant? Then they ovulate. Did they have a period? Then they ovulate. And if they aren't pregnant and didn't have a period, then they probably didn't ovulate. So I don't think we need to test progesterone levels. And most people also, or many people, don't think supplementation helps, with a rare exception. IVF, ovarian failure, and then for functional hypothalamic amenorrhea, these are where for many women in this pattern, simple description, which is not complete, they're pretty skinny, and they have stress or exercise a lot. If the brain isn't sending signal to the ovary, those people can need progesterone support. Most people, though, don't.